Okay, good morning, good evening, or good night, good afternoon, whatever it takes. This is Dr. Cortese from Clinica San Carlo in Milano. I'm going to present you this new update on the DCB use. I decided to have this very provocative title, which is DCB ready to upset some bad habits of cardiologists? Because there are some a point of view that I would like to discuss with you, and which I do not like so much regarding the correct management of our patients. This is my disclosure. And yes, I will go directly through the item. There are many physicians that just taking into account on the management and the treatment of a complex coronary lesion, they just ask themselves, how can I accommodate some metal into this lesion? And this is something that I'm trying to avoid, and I'm working in also in order to change the mind of many young physicians approaching this job. Why? The first point is that DES are very good. Currently available DES are good, but they are not perfect. The setting is native vessel disease, small but also mid-sized vessels. You can see here from this slide that also science is not a perfect tool for our patients. The point is that the adverse events in terms of target lesion failure are increasing through the years. So what can a drug-coated balloon add in order to avoid this limitation of drug-eluting stents? The first point is that there is no risk of acute malapposition in complex lesions, meaning highly calcific lesions and ectatic vessels. And then we have a low or maybe a no risk of metal associated adverse events after year 2 and after year 3. This is something that we have already heard for at the beginning for BRS, and the promise was not maintained at that time, but with DCB now we have also long-term data showing the safety of this approach. And then what is gorgeous about DCB is the use in the highly complex and sick patients, especially patients at very high bleeding risk. So this is a case of a patient which came to our cath lab for a cardiac evaluation for a prostate resection. He had a cancer, and he had a very important anemia with hemoglobin of 7.5. So this is a CTO, a quite easy CTO, which we manage antegrade. And after preparing the lesion, we used a long 2.5 by 40 magic touch. This was the final result. I admit this is not a stent-like result, but the patient underwent cancer resection after a few days and came back for a control angiography after 6 months, showing clearly how the vessel had an improvement in terms of lumen. This is something that we cannot have with the common metal stents. And then what do you want to see to get convinced by a good DCB in order to avoid the use of too much metal? First of all, you need to have a device which should have a good and an adequate deliverability. And then the other point is, okay, but if I have a dissection, how can I manage it, not stenting it? Then you also need to have a very robust clinical program. This is really important. And you need to have a direct comparison to currently available DES, possibly with a long follow-up. And then what about physiology? This is another point. We have very few data regarding DCBs for managed and evaluated intermediate with physiology, whereas we have a lot of data for the drug-eluting stent. The first point is the dissection. We have already seen with paclitaxel that if you leave a dissection which is not flow limiting, you go safe. You go safe, and you also have an improvement in the lumen during control angiography. So dissection is not a problem if the flow is good. Okay? You don't need to fix it. Okay, it's okay. And then we have the latest generation drug-coated balloon. I have shown this slide in gym previously many times, so I will go fast. This is a really new generation sirolimus coated balloon, which has many peculiarities which allow sirolimus to enter the vessel wall and to persist there. But if we have, and if we go a step backwards, we need to analyze the animal data in order to see if the device is a good one. And what we can see is that we cannot find any sirolimus after 1 month from the implantation. And the other point is that after 1 month, we can find some sirolimus delivered by magic touch at the treated segment, but not proximally, not distally, and also in any other organ. This is a good answer to the problems that we have seen with some paclitaxel-coated balloons. And then we have another case, high bleeding risk. 70-year-old diabetic woman who had a nuclear analysis which was positive 1 year ago, but then she decided not to go in the hospital to go for CAT because she feared COVID. And the patient came back to our cath lab 2 months ago for an anterior STEMI. Actually, she arrived at the peripheral center and she was brought to our hospital with CPAP. Okay, she had an acute pulmonary edema, but the problem was that she had also 5 of hemoglobin because she had an important bleeding. You can see here from this picture how the patient is white. So you can imagine the problem that we had to face with this patient, also to stabilize her. We managed to stabilize the patient and we found this not occluded vessel. This is the mid-LAD, a calcific vessel, complex lesions, and we decided to manage it without antiplatelet peros. We just gave some unfractionated heparin, cangrelor, scoring balloons, correct lesion preparation, and then dual DCB with this final result, which is adequate with good flow. We put paclitaxel and magic touch distally, and then we were able to manage also the bleeding with a gastroscopy done just in our cath lab, and then she had multiple catheterization. We went for a 48-hour of infusion of cangrelor, and then the patient went well. She had rehab, and then now she's safe at home. And we also have some easier cases like this one, which I did last week in one of our patients. Here, the patient had a critical lesion in the mid-LAD. And so the question was, why should we put metal here if we have a good lesion preparation? So we prepare the lesion and then we decide. Physiology by means of QFR show the critical lesion and a significant lesion. Then we prepare the lesion. We put the magic touch 2.5 by 40. This was the final result without metal. After a few minutes, this is the result. And we were happy to send the patient home just with a short duration of DAPT. And this is the final result of the QFR with 0.98. And then another complex case. We are not stating that we should use drug-coated balloon always. We use a lot of DES in our cath lab. But the problem is that, are you sure you want to pave all of this coronary lesion with drug-eluting stent? Our answer is not. We need to do in many patients, it's about 40% of our case history, an hybrid approach, meaning using either DES and DCB, because we know that the more metal, the more adverse events in the time. So this is our strategy. We decided to use 2 drug-eluting stents and a long drug-coated balloon in the distal part of this lesion with leaving a dissection. Okay, and this is the result after a few months when we went through a control angiography. We have long-term data, yes. Recently, there have been published the basket small 2 data, 3-year follow-up, no differences between stents, drug-eluting stents, either Taxus and Xience, and Sequent Please at 3 years. In terms of clinical events, no difference. And then we also have some latest generation drug-coated balloons with paclitaxel. This is Picoleto 2. I'm going fast through this. In lesion late lumen loss, which was the primary study endpoint, was really good, outperforming the drug-eluting stent. What about Magic Touch? Again, now in the last 5 years, we have collected a lot of data. This is the first data in native vessel disease with an angio follow-up, a core lab. What we have seen here is that Magic Touch is really well performing in native vessel disease in terms of late lumen loss, 0.09. It's very good data. And then we have another case, because here we are at GYM, so I'm happy to show some of our cases that we perform day by day. This is a CTO, which we decided to manage with a drug-eluting stent in the mid part, and then Magic Touch in the distal part with this very good result, also shown not only by angiography, but also by the QFR. So physiology is here, and we are using it quite so much. The other point, the other chapter is clinical data. eSpoon registry is the largest registry ever done with drug-coated balloon. The DCB used this Magic Touch. Again, this is a prospective, investigator-driven study. We just finished the enrollment of 2,100 patients, something more. We are really happy and proud to have led this multicentric study, international study, and we are analyzing the results right now during these weeks. We have the 1-year interim analysis follow-up, which is showing a very good clinical result with a MI rate of 2.3% overall. This is the total population. So we have 40% of patients with instant restenosis and also patients with native vessel disease. Okay, 600 patients at 1 year, MACE rate 5.8%. This is published data. What is the future? The future is Transform 1. This is a study that I'm leading with the Professor Serraios, native vessel disease up to 2.75, lesion length up to 30 millimeter. We want to see in this mechanistic study if Magic Touch is performing as or maybe even better than Sequent Please. We have core lab, but we also have OCT. We recently decided to increase the size of the vessel to be enrolled up to 2.75. Randomization, as I said, is between Magic Touch and Sequent Please. This study is sponsorized and is being enrolling patients in this period. And then we have Transform 2. Transform 2 is a very important study to us, native vessel disease between 2 and 3 millimeters. Here, after lesion preparation and the absence of flow-limiting dissections, patients will be randomized between Xience and Magic Touch again. After final assessment, we will go for the 12-month clinical endpoint, which is TLF. And this will be with 1,200 patients, the largest randomized clinical trial with DCB ever. So my conclusions are quite fast. DCBs are a major player in interventional cardiology now and in the next future. Magic Touch has shown consistent data in terms of deliverability, safety, and efficacy. And I thank you for your attention.